I think time is, for the sake of time, we will move to our next lecture, that is how to manage the proximal stumpless BKT CTO, and it will be delivered by Professor Sheung Woon Rha from Korea. Professor Rha, can you hear us?
Okay, can you hear me?
We can hear you.
Okay, Dr. Ali, can you see my slide?
We can't see your slides.
Can you see?
Not yet.
Yes.
I shared the screen, but can you see?
Not yet.
Yes.
This is Texas.
Not yet?
Yeah. Yeah, now we can see your slides.
Can you see?
Yeah.
Okay, may I start?
Yeah, you can start.
Okay. The chairman, Dr. Ali, stayed in my institute for, I think, more than 1 year as an international visiting fellow. It is my pleasure to be here, this meeting. I remember the Pakistan Live, I was in Islamabad before with Dr. Ali. It was a pleasant memory for me. I hope I can be there in offline in the future.
We want to see you next year.
Yes, I'm working not only the complex coronary, including CTO, but also complex endovascular. I was the president of the vascular intervention, also many complex intervention in Korea. So for the isolated BTK, I prefer to using ipsilateral 5-branch short sheaths for the BTK, because we can use all the diverse device for the ipsilateral route using 5-branch. So ipsilateral BTK CTO, I prefer to use the angiocatheter-based intervention first, because we can quickly switch from the CTO wire, 14 or 18 based CTO wire, to the 3-5 based, especially calcified region. We need to use the microcatheter or the angiocatheter supported subintimal tracking, especially the 1.5J, the thermal wire angioplasty. So this is my preferred 14-18 wire CTO wires. The sliding technique 3.5 milligram command ES series, or the some selective CT wiring, I prefer to use the RSI wire series. The CT wiring is the key for the stump, especially short segment CTO stumpless wire entering. Stiffer short segment navigation, the tip shapering is important. The sliding technique, command series is good, but the stiffer CTO, the RSI series stiffer wire, controlled wiring is important. However, once you enter the suspicious stump, it's sometimes better to do the subintimal tracking, because that will not going outside of the vessel area. That can be safer than the intraluminal CTO digging. That can going outside. So especially once you track down into the ankle level, it's better to switch. But that is an angulated area. It's better to go with the 14 system. Otherwise, it will rupture. So these are the available DCB, or the monorail, or the long or the tapered balloon in available Korea. Only one non-compliant balloon is available in Korea. So this is some case, no stump area. This is one representative case. As you can see this here. Here is a total stumpless, proximal stumpless, only peroneal artery remained. No definite distal stump, nothing left. Critical limb ischemia. You can see here. However, you can be suspicious of this angulated area. There may be some area of initiation point of ATA. some this angulated portion, some suspicious area of starting point of a PTA, peroneal start, only peroneal remained, but the mid portion total occlusion. Some collateral remained, but nothing remained. What would you start? So this either the SFA is okay. So we can start 5-branch puncture ipsilateral. I prefer other Terumo, I don't like because too slender, you cannot do the contrast injection with the 5-branch catheter. So usual 5-branch short sheath and the long catheter, and then you can start with the intraluminal or the primary subintimal attempt. I developed this Android catheter from Korean company, so easy deliverability. You can use the short segment, the easy small amount control, because many are CRI patients. So strong support with the preventing ocular recall once you do the balloon angioplasty. And once we canalize, we do the long balloon, especially the tapered balloon is effective, only 2 or 3 times balloon angioplasty. And the external closure device with the wings closure is usual practice. As you can see this, another CT angiography or the fluoroscopic or rotating angiography, you can see some fluoroscopic calcification marker and the symmetricity or the floppy and some spotty calcification and the contrast some island. You can see many clues from the CT or from the angiography. So bilateral CT angiography with the spotty calcium demarcation, and you can compare with another BTK anatomy. Fluoroscopic calcification and prolonged angiography is sometimes helpful. Collateral angiography and the common sense in anatomy, you can expect in some route. And the huge expense you can tell some expected route. So you can attack direct. You can do some IVUS guided or the 3-5 some fluoroscopic guide and direct 3-5 wire attack or the 14 dedicate 18 CT wiring attack, and then starting the intraluminal or the subintimal tracking. This is this case, previous case. So once I'm starting this, only peroneal left, but the peroneal itself also stumpless in the from mid portion. Then starting this 3-5 angiocatheter support 1.5 Terumo preformed loop is effective. So until this ankle area should not push it down to this ankle level because high chance of rupture. Then just a simple wiring, there may be high chance of spontaneous connection to the distal lumen. Then this way you can see many chance we can see the good communication to the distal ATA, distal PTA. Then now you can get some good information about the distal stump. Then proximal stump, still we don't have information. But you have some suspicious this angulated area. So by the 5-branch angiocatheter support, I prefer multipurpose. And then just digging with the natural curve of angled Terumo catheter, easily can penetrate. Then the angiocatheter deliver to the possible stump, then change it to 1.5J. And then just this preformed loop, just to push it down to the ankle level. And always should be observed this whether the loop can be enlarged or not. If the loop size is increasing, then you should do something. Otherwise, they can rupture. So if the loop size is increasing, pull back and push. Then if loop size increases, it's better to change it to supporting catheter into Rubicon 3.5. Otherwise, cannot be supported. So that is good to some calcified area. It's better to change it to more slippery supporting catheter. And non-calcified, you can do the 4-branch glide or the 5-branch MP. Anything is okay. Even after this 3.5 simple wiring, you can get good communication. Then simple 14 wiring and the balloon angioplasty. I prefer tapered long balloon 1.5, 20, 20, 2.5. You can do the fluoro guide or the empirical or the IVUS guided, the 2.5, the Japanese group they tell us get more bigger than the angiography finding. The 2.5, in our East Asian, 2.5, maximum less than 3.0.
Professor Rha, we have 2 minutes left.
Okay. Then this is good. Similarly, the ATA, same as this PT stumpless area. Then same fashion, the digging by the thermal wire and embedding this angiocatheter, change it to 1.5J, push it down to this PT because we know the definite distal stump. And then just a quick exchange it to the 14 wire system and the prolonged balloon inflation, 2 to 3 minutes, and BTK final. So this is a usual stumpless case. We can get many clues from the angiography and the CT. Okay, just a short presentation of this second case. This is a similar, the SFA, stented patient, critically ischemia, is a TP trunk CTO and ATS stump CTO, no information, only one transcollateral root distal PTA. So this patient, initially I started with this steep tumor, but cannot digging. So in this particular situation, you can try the 18 CTO like this. No Gaia PV and the Harvard series cannot penetrate, but only 30 gram astato could penetrate. You can see the contrast angio partly penetrated. This intraluminal wiring can be dangerous. So you don't know the exact route. So just embedding this angiocatheter and just try to start this 3.5 angioplasty. However, this will not be always happy. Sometimes make this kind of population. So as I mentioned, people should not give up. This nicely made route, but sometimes can make population like this. You can see this transcollateral route. So skip everything. So I did this transcollateral route, then do the small balloon angioplasty and the distal loop angioplasty and parallel wiring, integrated ballooning again, and then you can see that this the careful angioplasty from the distal root, everything can be sealed up completely. So should not give up, and we can seal up every ruptured area by the intraluminal passage by the transcollateral route. So stumpless, you don't need to worry about this kind of injury. You can, so baseline observation of the distal loop arch must be very important.
Professor, can you summarize?
Okay, I will summarize. So I showed you the just two cases of stumpless, proximal stumpless, but the distal stumpless also I developed a 5 method how to find out the distal no stump cases. So no stump in the proximal, no stump in the distal, no surgical option, no need of the venous arterialization in my cases in 95% or more. So you can do every BTK critically ischemic case by the endovascular. Thank you for your attention.
Thank you very much. We will have one comment from Parag Doshi. He's around.
Yes, I'm there.
Any comment regarding the previous presentation by Professor Rha?
I think it's an excellent presentation, and I really like his application of coronary CTO technique, specifically crossing the long lesions with a subintimal approach with a knuckle practice can cut down the procedure duration and also cut down the risk of perforation or rupture in the artery, because subintimal space is amazingly flexible. So I really like it, and also avoiding unnecessarily long procedures using subintimal approach, and that is one of the key teaching points. So in other words, you take a stiff wire and try to guide it slowly centimeter or centimeter for a long occlusion. It may take 4 hours and it may not succeed, as opposed to taking a subintimal approach and getting a procedure done. That is probably, I think, one of the best messages, if Dr.
Yes, my strong message is we are not doing the endovascular procedure for the BTK for the cosmetic reduction. We are proposing for the functional recovery and the limb salvage. So that this kind of long course reduction of the blood flow, either by the intraluminal or subintimal tracking, it doesn't matter. Just entry point and exit point recovery completely, and the salvage of limb is most important. And in our data, it's no problem either by the subintimal or the intraluminal, despite of risk. We are conducting now the randomized study by the subintimal or intraluminal, but until now, we don't have any difference. So I think the limb salvage is most important issue.
Dr. Rha, I think I can define my peripheral vascular procedures before coronary CTO and post procedure. So I've been doing coronary CTO since 2010 or 11. And literally within few months of starting the CTOs with the advanced technique and working that more hybrid and reverse cut, my peripheral procedure time dropped by literally 80 to 90%.
Yes, I think that either as a cardiologist, we can adapt in both extreme. The coronary CTO technique should be adopted in the complex peripheral, and we can get more inspiration from the coronary to peripheral, and peripheral safari technique we can adapt to the coronary CTO. Either can be adapted. So that's true. So I'm very happy with that kind of.
Thank you, Professor Rha. For the sake of time, we will move to our next speaker, which is Professor Nihat Kale. He's from Turkey. He's a good friend of ours, who will be talking about step-by-step endovascular management of iliac artery disease, basics to advance. Professor Nihat Kale.
Thank you, Jabal Ali.